The similarities, if we look at the imaging, the autofluorescence, they both have jet black autofluorescence, and on OCT, they both show outer retinal thinning. So we can't use those modalities to show differences. But in terms of the differences, in chirpy lesions, usually they're just an isolated lesion, whereas in our study, we found that all patients had bilateral lesions, even though many of these lesions were tiny, tiny lesions. So they had an average of 10 lesions per eye. So I think if you see a lesion, then you have to look out further and see, can you see these tiny little dot-like lesions or other lesions? If you do, then that's more likely to be associated with FOP. Also, there were things that we didn't find in these lesions. So we never saw lacunae in these lesions. We never saw cystoid macular edema in these lesions, and you often do see lacunae associated with regular chirpy lesions. Plus that we often saw pigment epithelial detachments that we don't tend to see as much in chirpy. So these little clues, I think, as our job really as an ophthalmologist, I think we're trying to determine, do we send this patient to a gastroenterologist for colonoscopy? And so some of those findings can help us decide whether we send the patient on or not.
¿Alguna otra pregunta para Edgar o para alguno de los presentadores? Jean-François, I have a question. Now that drugs have not been approved in France, what do you do with those GA patients? Do you tell them to follow any diet or their its formula?
No. No, we put them in the new trials because there are new drugs also that are explored, gene therapy. There may be a talk later about gene therapy in GA. That's all. I must say that before the final decision of the EMA, I had mixed feelings about the results, because on one hand it works, and on the other hand it's not improving at all, of course. And our patients in the studies, we told them very precisely, you will not get better. And after a few months, they come back and they say, I don't see better. So we tell them, we told you, but it's very hard to understand. There is a lot of expectation when you start the treatment. So that's the way it is. I think that besides the discussion we had yesterday in the meeting, function is important, and here function is not preserved, at least as we can measure it. So we'll see, but mixed feelings so far. I expected, beginning the studies, I expected better efficacy, and I'm sure the companies expected also better efficacy.
Paolo? Thank you, Jean-François.
Yeah, comment on these newer drugs for geographic atrophy, which unfortunately are not available in Europe. And I say unfortunately, because as Jean-François mentioned, function in terms of visual acuity is not the only measure we have to evaluate visual function. Think about glaucoma. EMA has approved a number of glaucoma, not based on visual acuity, but based on visual field loss. And that's just an example. So if you look at the trials for both drugs, there are groups of patients who can really benefit from being treated. So to me, EMA should have approved both drugs and then leave to the single country authorities the decision to limit the treatment to specific subgroups of patients. So to me, it's big limitations for the European patients not to have access to those two drugs. And I hope you can have access to those drugs in Colombia and Latin America.
Just a short comment. Those subgroups were defined post-hoc. And the European Medical Agency said post-hoc analyses are not powered enough to be very conclusive. So if you define a new subgroup and you do a new trial on this subgroup, then we may say yes. But you need a new phase 3. And Apellis decided not to do it.
Fernando. Thank you, Jean-François.
Thank you, Jean-François. Great talk. I think the issue is that patients need this medication. I agree with Paolo when you say that it's unfortunate not to have it in Europe. I have patients begging for some treatment for GA for years, and now that it is available, we can treat some of them if they understand all the facts and that there is not going to be any functional benefit. And they understand that they are not going to see an improvement in vision, and that still there is going to be some progression of the lesions over time, but it's going to be theoretically slower than if they were not getting any medications. So patients that have lost vision in one eye is a good example. They really want any kind of treatment, and it's good to be able to offer something for these patients psychologically. Just the fact that we can give them some treatment that I give every 2 months because it's the best risk-benefit ratio, talking about the side effects and benefit. So I think that if you're careful about what patients to inject, for example, being careful about not injecting patients that had autoimmune diseases, patients that don't have inflammation or history of uveitis, you're going to be less prone to have patients with inflammation. And even though I give both Icerva and Syfovre, I haven't seen any case with Syfovre inflammation, occlusive retinal vasculitis, or even mild inflammation. So I think it's a good thing to have it, but it's going to be expensive, and the benefit is very small. So it's a thing to consider, and it will depend on the patient's decision to get the treatment or not, really. But it's a good thing to be able to offer it, I think.
Carl is going to present also on GA.
Carl.
Yeah. Thank you, Carl.
Thank you. Those are fantastic presentations by all this morning. So I am going to talk about real-world cases tomorrow for GA, and we'll go over, like, would you treat, would you not treat? But in regards to this excellent presentation, Jean-Francois, thank you for presenting that data. I find a couple things very interesting. What's, to me, most interesting is that you have, with the pegcetacoplan trials, you have reduction of lesion size, progression, that is statistically significant. But only one of the 2 phase 3 trials met its primary endpoint. I find that most significant and probably problematic for the EMA. In addition to function, I presented vision loss data at 1 year. Fernando, you were there for that presentation in Seattle, ASRS in 2023, where we had a relative reduction of like 56% relative reduction of persistent vision loss with ACP, avastin captive pegol. Well, great. A year later, when we did the 24-month data, that didn't hold. So that goes back to the function. So, we are working with these companies now to try to demonstrate function. Is it going to happen? We'll see. Gene therapy I'm going to talk about gene therapy later today, but it's for wet AMD. The gene therapy from Gyroscope did not meet its primary endpoint for subretinal gene therapy. We were in that trial at my office. Furthermore, Aviceta in the Siglec trial has shown some nominal visual benefit. I'm not presenting that today, but if anyone wants to go over that data, I have it on my computer. I'll be happy and delighted to go over that. But there has been a little movement of the needle with them, and they're still in trial, but the earlier phases showed some benefit. So we will see. I mean, it is a super hard conversation to have with patients. It eats up chair time like no other. And you're right, the benefit is somewhat nominal. But like, where do we go? These patients have little hope. And yes, I like to also treat the worst eye first. I think you're 100% correct. But what if the worst eye is due to neovascular AMD? What if only one eye has GA? The worst eye is going to be the GA eye. So there's so much to think about, so much conversation to have, and it rarely involves one visit. Where I live in South Florida, I'm sure much like in Paris, it's not the whatever you think, doc, is best, I'll do it. That's not how it works for my patients. It's always like, talk to my daughter who's at MIT, or my son's a lawyer in New York, or let's all have a family discussion time and time and time again. And then they say, I'm not getting better. And I say to them, this is the best you're going to see for the rest of your life. and it's sobering, it's sad. It's like Alzheimer's for vision. But wouldn't we all want to take a pill to preserve our memory if we were diagnosed with Alzheimer's? Every one of us would probably say, yes, I want that pill, but would we know how fast our memory would be declining if we didn't take it? And that's how I look at it.
Thank you, Con.
So in Australia, as Jean-Francois said, pegcetacoplan has recently been approved, but it has not yet been federally subsidized. We're still waiting on that. That's the only second country I know after the United States where it's been approved. There was an interesting study from the ARIDS group looking at geographic atrophy, at least based on color fundus photography, not on autofluorescence, and they showed a reduction of about 40% in GA growth lesions. So I'm actually now giving ARIDS vitamins to all my patients who have geographic atrophy. But my question really to Jean-Francois is, we've learned a lot from these studies that we didn't know when they first started. And I think one of the things that we've learned is functionally it takes a long time to show changes. And we might not be able to show changes very easily within a 2-year period of a clinical trial. So if you were to construct a new clinical trial, how would you do that? What would your main functional outputs be?
That's an easy question. No, I think the function, we cannot do it better. I mean, microperimetry is the best we can do, and it is feasible in trials, but it's time-consuming, it's exhausting for the patients, so it's not feasible on daily life. So I think we have to stay with what we have, but for a new trial, I would select a subgroup of patients. You remember that at one time point for autofluorescence, we were looking for some patterns of hyper-autofluorescence at the margin based on the work of Frank Holz a long time ago. I'm not sure this is very relevant based on the results that we've seen. So we have to look in details in those studies, those that succeeded and those that failed. Same for lampalizumab a few years ago with Roche. Look at fast progressors and do a prospective trial on those fast progressors. But it takes time, it takes money. When I suggested that, probably as many of you, when I suggested that to Apellis, they answered, money is not a problem, so that's good news, but they said no. And I think if they said no, it's because they do not want to take the risk that a new trial will be negative. So they prefer to stay with what they have instead of a new challenge with new trial. So what my expectations are with Siglec, I agree, new company, new drug, new study, very clever selection of new patients, and let's see what it does in 3-4 years.
Thank you, Jean-François. Great discussion. Gracias a todos por la discusión. Seguimos ahora con el doctor Gerardo Ledesma.